All right, good afternoon, everyone. Welcome as you're getting logged in, and thank you for joining us today. Before we get started, we just wanted to share a couple of quick announcements. This seminar is being recorded, and the recording will be posted along with the slides on our website after the event. There are CHEST and MCHEST continuing education credits available for attending this webinar. So details on how to receive credits will be emailed after the event, so please look out for that. All participant microphones are muted. If you have any questions or comments during the seminar, please enter them into the Q&A box in your WebEx panel or the chat box in your WebEx panel, as there will be time for questions towards the end of the presentation. Now hand it over to Dr. Maria Fernandez to introduce our speaker today. Thank you.
Welcome. Thank you for joining us for our third in the series of webinars from the Texas Institute of Implementation Science. Today, I'm really pleased to welcome an excellent implementation scientist and friend, Geoffrey Curran. Dr. Curran's research area has been health services research with a focus in the areas of diffusion of innovation in a variety of health settings and predictors of treatment engagement and outcomes for mental health and substance use disorders. Dr. Curran is a medical sociologist. He's a professor of pharmacy practice and psychiatry at University of Arkansas for Medical Sciences. And for the past 20 years, he's been continually funded by the NIH, the VA, and other funders to develop and test a range of implementation strategies designed to support the uptake and sustainment of evidence-based practices. He's also written widely on research design and methodology and implementation science. He's currently the director of the Center for Implementation Research, which is supported by the Translational Research Institute through U.S. National Center for Advancing Translational Science of the U.S. National Institutes of Health. The center is devoted to developing and testing implementation strategies across a wide range of service contexts, assisting the implementation of practices within community practices of implementation, and training the next generation of implementation scientists. I know that along with many of you, my work has been heavily influenced by Dr. Curran's writing and research, and so we are extremely pleased today. So turning it over to you, Jeff.
Okay, well, thank you so much. So can folks hear me okay? Yes? Okay. All right, so the focus of this talk is trying to give a brief overview of hybrid effectiveness implementation designs. And so the goals are as follows. To talk about this hybrid design concept, which is, trying to combine elements of clinical/preventive effectiveness research with research more focused on uptake type questions. We are going to be talking about three hybrid types, which we have proposed. Hybrid type 1, which focuses more on implementability, if I can make up a word, of a clinical intervention, intervention, while we are testing its effectiveness in more of a regular effectiveness trial. Hybrid type 3s, which are sort of the inverse, where those are focused on testing uptake strategies, often in a comparative way, but also while documenting clinical/prevention outcomes at the patient level, and trying to understand those outcomes as a function of adoption rates and fidelity. And then hybrid type 2s, which is kind of a dual approach, dually testing interventions while also testing uptake-based strategies. So after I cover the basics of these designs, I will review trends in their current use, I'll give a few examples. And towards the end, I'll also summarize some of our newer thinking on specification, measurement, and reporting. Maria asked me for this session to focus more on the type 3s and the type 2s, as she thought that would fit better in with your current webinar series. So the first few slides coming up are largely drawn from this manuscript, which was our first paper proposing these designs. Some of the later slides are reflected in this paper from 2019, which kind of gave a newer, updated intro to these designs. But first, I'm going to start with this paper, which has been helpful for me when teaching this hybrid stuff, to often use some very non-sciencey language to help us get on the same page here with this complicated process of talking about combining implementation research with clinical effectiveness research. So in this talk, you will hear me use the term "the thing" to refer to the intervention, the evidence-based practice that is under study. And effectiveness research often looks at whether the thing works, meaning patients who get the intervention get better as opposed to those that didn't. D&I research looks much more at really the science of how best to help people or places to do the thing, okay? And the interventions that are most common in this kind of science, we often call them strategies. And in very simple language, they are the stuff that we do to try to help people and places to do the thing, okay? And the main outcomes which we often focus on, which I'm sure that you've learned about thus far in this D&I space, are using simple language, basically how much and how well that these people and places are doing the thing. So in a hybrid study context, we are dealing both with effectiveness, with how well the thing works, but also on how best to help people to do the thing. And I found that this very simple language can be helpful, especially in groups like this, where there's folks that come from, different contexts. They are supporting, varying contents, interventions. So this is sort of a level set for us. Okay, so why hybrid designs? In our first paper, one of the key arguments that we floated, was we were hoping that the speed of moving research into routine practice could be improved by considering these hybrid designs, which combine elements of these both sides, or combining research questions from both areas. Maybe we don't need to wait for perfect effectiveness data before moving into uptake focused research. Maybe we can, for lack of a better term, backfill effectiveness data while we are focusing on testing uptake strategies. And a later question, that we have come to, but I think is really crucial, is how do clinical outcomes relate to levels of adoption and fidelity, which are achieved by our strategies. I think that's a crucial question which we don't know a whole lot about in our field, and we are not really going to be able to answer that question without data from both sides. So here's a look at a more traditional research pipeline, and so I'm drawing this funky shape here to indicate the kind of the lines that we're trying to blur here between effectiveness research and that more focused on uptake. So in our first paper, and still now, we have proposed 3 types of hybrids, hybrids 1, 2, and 3. Now, hybrid type 1 is focused much more on testing of the thing. It's much more of a traditional clinical trial, but with additional work focused on trying to understand more of the do the thing questions, barriers, facilitators, and what might be needed for future uptake in the real world. Switching over to hybrid type 3, which is kind of the inverse. These are studies that are mostly focused on testing of the do the thing of these strategies, often in a comparative way, using cluster randomized trials or step wedges, but retaining data collection on those clinical / prevention outcomes of the interventions that are being supported by these strategies. And then a hybrid test, the hybrid type 2, which is this middle ground, which is likely a little more complicated, but we're really doing a dual test here. We're testing the thing or a thing, likely still a randomized patient level trial, at the same time testing strategies to support how best to do the thing. And again, for this talk, I will focus more on hybrid type 3 and hybrid type 2. However, I will just say a little bit about hybrid type 1. I only have this one rather busy slide. So hybrid type 1s, as I noted, are largely a regular clinical effectiveness trial, but people often add an implementation-focused process evaluation towards the end to try to get a sense of things like this. What seemed to work and what didn't around the delivery of the intervention during the trial. Barriers, facilitators, things maybe that had to be changed in order to, have it work better. Asking questions like how might the intervention need to be adapted for going forward to maximize uptake, trying to get people talking about the kinds of strategies which might be needed to help folks to do the thing in the real world. So these studies from a design point of view are often, this process eval is often a qualitative or mixed methods study, often focused on the locations where the trial took place, or if there aren't a large number of those, adding what we are calling naive sites, those that were not part of the trial but are like the places who are the likely targets of future rollouts. It's very common to see folks use the frameworks like CIFR to help, guide that analysis, driving interview guides, codes of that analysis. And then folks using a variety of methods, site visits, observations, interviews, and surveys. Okay, so that's all I'll cover for type 1. I will now flip to hybrid type 3, kind of its inverse. So again, the main point here is to test strategies, often in a comparative way, but also gathering information on clinical or prevention type outcomes. So these trials are largely focused on comparing strategies. Randomization is often done at the level of the provider, clinic, or system. Clinical outcomes are always secondary. Some of the indications for why these might be useful, back from our first paper were issues like this. There are times when we, especially in larger healthcare systems, proceed with these rollouts of practices which might not necessarily have gotten a full look at their effectiveness. A lot of this work came from our VA work, where those kinds of mandates and rollouts happen frequently. But also too, what we are seeing now as a growing interest in exploring how these clinical or prevention effectiveness data outcomes might vary by level quality of uptake. So when you're thinking about trying to possibly propose this type of design, here's a few things to try to keep in mind. How much power you got. This is really the same issue with non-hybrid uptake-focused trials, where there is often not a huge number of locations or sites. It's really important for folks to use outcomes frameworks. I've listed, two here that are really popular, which I'm sure that you've heard of. It's really important in a hybrid type 3 in your background to talk about the evidence that is known about the strategies which you have selected and you are testing. These are the interventions that are the focus here. And so one really needs to focus on the known evidence base of these strategies as part of your justification. Also, too, in our science over the last 3 to 4 years, we are seeing a lot of folks, our RFAs, PAs, asking us to pay attention to mechanisms of actions of these strategies, meaning how they work, how they affect more proximal outcomes around attitudes, around learning, around culture, around climate changes, which then sort of precede these distal, more re-aim type outcomes, adoption, fidelity, that are often our main summative outcomes. I think that we're also getting a lot of calls now to make sure that we are trying to cost our strategies. Even if it's just a cost accounting analysis, but we are also seeing now cost effectiveness analyses of cost per adoption unit, fidelity unit gained, from these strategies. And I think that's, really exciting work and being more and more common. Now, often a key challenge is around how much time and effort that you'll need to spend to collect these clinical outcomes. First, I think it's really key to ask, well, do I really need them? I think that there are certainly many interventions where we actually might not need to do a hybrid 3, and maybe just a more traditional uptake trial is certainly fine. one example, of a study that I'm actually writing now is focused on supporting vaccine uptake in community pharmacies. And, we are not actually doing a hybrid type 3. It's focused more on adoption issues and not really testing the effectiveness of the vaccines, which we don't think is really necessary. But a key issue is trying to find measures that work but don't break the bank or break the budget of your study. Hybrid type 3s are extremely helped if there are measures which are available in data sources, medical records that you already have access to. So studies focusing on diabetes, hypertension, where there seem to be A1Cs and blood pressure measurements, that are out there that happen on a routine basis. For mental health studies, for example, which is kind of my main previous content background, we don't have a lot of those measures that are used as part of routine care. So in those cases, you often see primary data collection proposed, which certainly is, harder to pull off. And in cases like that, folks often can't get data on every single patient that was part of the study. And you are seeing folks now, doing some sub-sample analyses there. Here's one example of a relatively straightforward and not too large hybrid type 3 that I wanted to share with you. Relatively small, focused only on 3 large hospitals. The main comparison is between 2 uptake strategies, one more of a standard condition, like a standard training plus access to a treatment manual here called the Mission Vet Manual for addressing co-occurring SUD and mental health disorders among homeless veterans. And then, so having a standard training, which is mostly, training plus manual, and then adding in more strategies, planning, supervision, monitoring, audit, and feedback. And so in this case, they randomized case managers within hospitals and then studied outcomes which they had access to in their medical records for those veterans served by those case managers. So adoption, which they measured as a threshold of % of their caseloads, which they offered this intervention to or provided it to, and then effectiveness outcomes, were SUD, mental health symptoms, and functioning measures, which were already happening in the record. Okay, so here's a few more examples. Some of these are larger studies. Some use a stepped wedge, some use a smart design, and I highly recommend you checking those out. Okay, now, so let's move on to the more juicy one, the hybrid type 2 designs. So as I said here, it's kind of a dual focused study. We're trying to test a clinical intervention and test an uptake strategy or compare 2 uptake strategies. So these studies often look like this. They often are a clinical a clinical effectiveness trial nested in an uptake trial of 2 or more strategies. So a dual randomized design at both levels, or a clinical effectiveness trial nested in what I call more of a pilot study, a non-randomized study of a single strategy or single package of strategies, which all of the places get, okay? Indications which we wrote about in our first paper about, when a hybrid type 2 might actually make sense is things like this. Clinical effectiveness data are available to some extent, though perhaps not for the context or population of interest for your study. You already have data on barriers, facilitators to uptake, enough to base a proposed uptake strategy or strategies which you want to test, okay? So those seem to kind of be the prerequisites for doing a hybrid type 2. Here's a few more design considerations. So in our first paper in 2012, we wrote about these dual options, the dual randomized type, and then this more effectiveness trial nested in a single arm study of one strategy or one strategy package. In our current review of about 170 to 80 hybrid studies which are published, about a third of those, maybe a bit more, are hybrid type 2s. We are seeing more of the latter, so more of this kind of study that is only doing a pilot test of one strategy or one strategy package, okay? When looking at these published papers, most of them specify the effectiveness aims as the primary aims. However, the dual randomized ones often claim, dual primary. It's important for a type 2 compared to a type 1. It is important to have an explicitly described uptake strategy that is thought to be plausible in the real world. And this is a clear distinction from a type 1. In a type 1, more regular effectiveness trial, there's a lot of these delivery strategies which are heavily tied to researcher behavior. They're high resource, paying clinics to take part, paying interventionists. And in a type 2, there's less of that and more of an attempt to make a strategy or comparative strategies that are hypothesized to be feasible and potentially effective in the real world. Hybrid type 2s always measure these more summative outcomes like adoption and fidelity. In a hybrid type 1, you often don't actually see those measured, and you'll see more of a focus on feasibility, acceptability, and fit type issues. For hybrid type 2s especially, I think it's important to be clear about what the intervention components are versus what the uptake strategies are. In lots of the papers, this is not always clear, and I don't think it's always easy to make that distinction. For example, we see differing approaches to how people classify what I would call delivery format. If an intervention is delivered over the telephone or over televideo, is that an intervention component, or is that an uptake strategy? And I've seen it argued both ways. I have my sort of strong feeling here, but I will leave that maybe for a later question. Okay, so here's some of the possibly more worrying stuff that one might have to deal with in a hybrid type 2. What if the implementation strategy leads to poor adoption and poor fidelity? It is possible that your effectiveness trial could get compromised. In your effectiveness trial, you need adequate numbers of patients to get the thing, and you need it to be delivered with adequate fidelity in order to get the correct test that you want of that intervention. So what might be some ways to minimize this happening? And we recommend several here. One is to try to use strategies that already have a relevant evidence base. Next, I think it's crucial to build in adoption fidelity benchmarks in your study to try to make sure that these strategies or the strategy package which you're using is actually getting you enough participants and is being delivered with fidelity enough to make your effectiveness study actually work. And you need to build in measurement and plans to address any poor adoption or poor fidelity which you might be seeing, especially at the start of your deploying these strategies. And it also makes sense to build in time to deal with that possibility of having to possibly stop the trial for a short period of time to make adjustments to these strategies. So anybody getting queasy over this idea? It's certainly understandable, but you know, a number of folks, you know, have had excellent, you know, luck, you know, with these designs following these guidelines. So just real fast here. Here's a few examples of hybrid type 2s. The first is a relatively small study, which is in more of the clinical effectiveness trial nested in a pilot of one strategy package, which every place gets. You know, here, still a small number of sites. It was powered on the patient level effectiveness study. However, they delivered the same uptake strategy at both places. And those outcomes dealt more with feasibility, acceptability of these strategies, which, you know, was online training, audit and feedback, and facilitation of these mental, you know, of this mental health treatment. And the goal here was to still focus more on effectiveness outcomes, but to pilot test this strategy, which, if found to be feasible, acceptable, and show preliminary effectiveness of strong fidelity and strong adoption, it would then be a focus, which it was, of a later trial, which was more focused on comparing that strategy versus one more basic. Okay, so this was preparatory to a larger trial focused on comparing these strategies. Okay, so here's a more recent dual randomized hybrid type 2 by Bryant Garner. His protocol papers were published in 2017, and this was such a large study that he did 2 protocol papers, one for the AIM-1 effectiveness side and one for the AIM-2 uptake side. He is currently publishing outcomes papers now, which are, really, really strong. So in this case, he was working in 40 AIDS service groups, or ASOs, and they're close to 1,900 patients in those settings. And so the patients were randomized to a clinical intervention compared to usual care, in this case, a referral for substance use issues. And the ASOs were randomized to 2 different strategies. One, a more standard approach, which is commonly used in the SAMHSA-funded addiction transfer centers. And then they added in this facilitation component. And so they were randomized to either or of those. And this happened all at the same time, with, a lot of great measurement of, both clinical effectiveness and, a number of, standard uptake outcomes. And he was able to show that the clinical outcomes were better among the patients who received the intervention with greater fidelity. And, that's a really wonderful and key finding, I think. Here's a few more type 2 examples of both kinds, the dual randomized and not. So just a couple more slides here. Here's some newish thinking on hybrid designs, which is based upon our current review of a large number of published studies, but also our frequent grant reviews that we do, and frequent consults. One of the things that has happened since this first paper in 2012 is that there really seems to be changing thinking around lack of fixedness of interventions, and more and more calls to constantly adapt to fit context and other factors, which I think leads us to think differently about the whens and whys of these hybrid designs. For hybrid type 1s, we are wondering, if these should be less of a special case, but maybe more routine or more of the default. If effectiveness research is supposed to be the last step before trying to get people to do the thing, then why not all or most of them have some focus on these uptake questions. We are seeing folks now doing hybrid type work with efficacy trials, with small effectiveness pilots. So this concept, seems to be being applied, in a wider frame than we first wrote. As I mentioned, for hybrid type 2 designs, we are, really asking people now to fully justify their selection of a hybrid type 2, and to think about and have in there these fail-safe measures, which I mentioned earlier, and really make the scientific premise argument for your grant based on evidence of both the intervention and the strategies that are being tested. We're also wondering if hybrid type 3s, should be less of a special case also. I often tell a story of going to a D&I meeting which was focused on hybrid designs. I was in the audience just watching, and somebody got up and asked a question of these panelists who were doing designs and sharing results. And he said, well, I mean, when wouldn't we want to have patient outcomes also? And I kind of went, oh, that's a really interesting question. Certainly, if you go to certain funders, for example, NIMH, they require you to get these outcomes. So they don't really fund traditional uptake-focused studies with no clinical outcomes. They are all hybrid type 3s, okay? And also too, I mean, as a field, I mean, I personally think that, we really need to prove how much fidelity is key, to driving those clinical outcomes. I mean, I think that we make this large assumption that fidelity has to be, super strong. It has to match the fidelity achieved in the highly controlled effectiveness studies. And, that is an assumption. And I think that we really do need to study that closely, because there are, real feasibility and cost effectiveness implications here if that might not be the case. My last slide here is, here's a few issues that folks can run into when trying to get hybrid designs funded. A common one is reviewer disagreements on how much evidence is enough to start to focus or bring in these uptake questions. You have some folks who seem to, really want to go slower and make sure that we have all of the effectiveness data that is needed before we focus on uptake issues. And then you have folks like me that are more in the enough already, let's get people doing these darn things and study this stuff at the same time. People seem to run into problems when the interventionist and or the context is really different than the prior trial work. And how do you make that case that it's close enough to how it's being delivered in the prior work, but still in a good place to focus on uptake. We see people, having really not enough barriers, facilitators upon which to, base proposed strategies. And we are seeing too that, folks don't have enough data in hybrid type 3s especially, but some 2s, not enough pilot data on the implementation strategies, which especially in a type 3 are the key interventions that are being tested. So that's really, really key. So I will stop there and to take questions.
Thank you so much, Jeff, and thanks for leaving time for questions. We do have a few. So the first one is, do you have a guide that helps determine which hybrid type should be employed for a given intervention?
Is this a plant question?
It came through the chat.
Oh my gosh. So if I had 10 more minutes, I would have actually shown you this, which is our basically 6-question guide to help you decide based upon where your evidence is around the intervention, how much you know about your context, how much data that you have on potential strategies, how much other people in your context have already tried strategies and they failed. So that's a good place to start. So I don't have time to go through all of them, but they kind of look like this, okay? Focusing on nature of the effectiveness data of your thing, how much you think the thing needs to be adapted, how much you already know about barriers to uptake in your context. Are you starting from scratch or other people have already tried stuff here? How much pilot data that you already have on a strategy which you want to test? And then the funny one, if answering all of these questions, do you still want to actually do a hybrid design? And if it's no, we certainly understand, and you can feel free to run screaming from the room. However, if you still want to go forward, seek protocol papers. There are scores and scores and scores of them, and come to these webinars and call folks like me on the phone.
Thank you. And someone asked a follow-up question if we can include these slides with the others when we upload them.
Oh yeah, yes.
Great.
So I offered to Ricky to also share like just the one-page Word version of these questions. Yes.
Excellent. Thank you. Another question. Would you say the presence of a clinic facilitator who promotes an intervention would be a type trial?
Say that last part again, sorry.
The presence of a clinic facilitator who promotes an intervention. What type of trial would that be? I'm assuming it's testing the presence of a clinic facilitator.
Right. So if it's part of a strategy that you think is feasible and effective in the real world, I think it would likely be part of a type 2 or a type 3. It's certainly possible that an effectiveness trial might deploy somebody similar, but they might be paid for from study funds, and how they do the same thing might not easily translate to the real world. So I would say it kind of depends on the real worldness of that approach, but I would think that for the most part, though that would likely be part of a type 2 or a type 3.
Okay, another question, and this one's a bit long. So it says, as one who's interested in environmental influences on health and behavior, is it ever appropriate to first focus on just getting the environmental change enacted? For example, a policy of breastfeeding in the workplace or an environmental modification such as improved parking structure without having evidence for its effect on behavior or health? And do we limit our science for environmental change because we must first show changes at the individual level first? And they're relating this from going from a hybrid 1 to a 2 to a 3.
Okay. I'm not fully following it, so maybe just
I think I might have an
summarize it for
answer
me.
to that one.
Okay. Yeah.
So I think that you can have just a regular study or a hybrid at any level, that hybrid 2 or 3 that is focusing on environmental influences. I think perhaps the misunderstanding or misinterpretation is that any intervention focusing on environmental influences is a type 3. And I would say that that's not correct, that you could have a hybrid type 1 or in fact no hybrid at all that is focusing on change at the environmental level.
Well, and change on what kind of behavior? Like, are those changes being done to try to change patient behavior directly or consumer behavior directly, or what are those actually trying to adjust?
So let me move on to I'm not sure on this question.
Okay.
I think the question had to do with the relation between environmental change and behavioral change, and whether an intervention focused on environmental change had to be predicated on whether that environmental change also influenced behavior or not. But I guess what I was saying is that I think that that's a separate question than
I agree.
And the question about hybrid designs.
Yes, I agree.
So another question was, for the type 2, when you're doing a pilot of one implementation strategy, do they typically articulate a research question related to the implementation, even if they're not manipulating it? You talked about the typical type 2. Okay.
Yeah, and so as it's often framed as a pilot test of that strategy, the pilot level outcomes are often, the key ones noted. And, folks argue that, we are going to measure satisfaction, appropriate fit, feasibility, preliminary effectiveness of it. And that's the bar that we are trying to meet. So it's similar to really any pilot type study of any intervention, but the strategies.
Thank you. Another question. This is, let's see, from Carmen Valdez. In the first consideration, and I'm assuming that means hybrid type 1, when Dr. Curran says effectiveness data, does he mean from pilot data, or is he thinking of RCT data?
Most of the type 1s are RCTs, but I have seen hybrid type 1 approaches that are published and got funded, which were with, pilot studies, small studies. Philosophically speaking, I can say that, I am in the camp that efficacy studies, early pilot effectiveness studies, I'm not sure that there's a bad time not to focus, at least to some extent, on the implementability of these interventions, and to try to study and maximize their potential to be adopted, meaning focusing on the characteristics of those interventions themselves and trying to make them as, as maximally operationalized for easy uptake.
Great, thanks. We're getting through a lot of questions here. This is awesome. The next one is, effectiveness tests the thing in the real world after proven efficacy. How is this different from implementation?
Well, there are some who use this same efficacy effectiveness language when it comes to testing the strategies too.
Okay. I have another, oh, sorry, go ahead.
Yeah, like in our VA work, we actually had in the early 2000s a multi-step process where folks were really wanting us to do an efficacy study of a new uptake strategy and to basically do it in a small number of sites that we would expect, due to their relative culture and climate, that this strategy would have a strong chance of succeeding. And then after you show that, then move to larger effectiveness type studies of the strategies where you're trying to test them in a range of likely higher and lower performing contexts.
And I guess implied in that question is, how does a regular effectiveness study differ from a type 1 and a type 1 hybrid? And I think some of the things that you described about, making sure that there's an implementation aspect and implementation outcomes as part of that hybrid one is one of the distinctions. Related to that is another question. Many people think that a type 1 is what we normally would do with the implementation component of analogous to process evaluation, right? So yeah. And just what are your thoughts on that?
Yeah, I mean, I would argue that, well, my understanding of a process evaluation is largely focused on what happened during the trial. And in a hybrid type 1 approach, that's certainly part of it. But I think a key difference is we add research questions, things like, okay, how might the thing need to be adapted for optimal uptake in the future? How many of these delivery strategies used during the trial to make it happen with high fidelity, how many of those do we think might be able to move forward and be part of a real world uptake approach, or how many of those aren't, and what might be the new strategies which would be needed, which we didn't use in the type 1 study, to actually try to make it work in the real world. So what additional or new strategies might be needed? So the hybrid type version isn't, to me, just a process eval of what happened in the trial, but it expands it further to focus more on the more general uptake questions. And really trying to position the next study to test those strategies.
That's excellent. Thank you so much, Dr. Curran. We want to thank all of the participants, and Ricky, if you could just wrap us up here. Thank you, everybody.
Sure, guys. thanks everyone so much for attending. Slides and the recording will be posted on our website by the end of the week. And if you haven't already, please register for our last seminar in this series on December 1st at 2 p.m. The link is in the chat as well. Thanks, everyone. Thank you, Dr. Curran.
Bye, everybody. Thank you. Thanks so much, Jeff.
Thank you for having me.